Welcome all. It's a pleasure to present this wonderful program called HRCT 360, Classes in Session. Today we are going to discuss the features and patterns of interstitial lung disease on high-resolution CT tomography with specific cases of rheumatoid arthritis-associated ILD, systemic sclerosis ILD, and interstitial pneumonia with autoimmune features. My name is Virginia Steen. I'm a professor at Georgetown University, chief of the Rheumatology Division, and I'm joined by my colleagues Dr. Robert Su and Juan Carlos Battle. If you'd like to introduce yourselves, please.
Thank you, Virginia. Hello, everybody. My name is Rob Su. I'm clinical professor of radiological sciences and the vice chair of radiology education at the David Geffen School of Medicine and UCLA Health.
Thanks. Hello, everyone. Welcome. My name is Juan Battle. I'm the Chief of Thoracic Imaging at Baptist Health South Florida in Miami, Florida, and an Associate Professor at FIU College of Medicine.
This presentation is made on behalf of Boehringer Ingelheim Pharmaceuticals, Inc. The company has provided financial support for this program. Presentation content has been reviewed for consistency with FDA guidelines. So, pulmonary fibrosis and interstitial lung disease are very common manifestations of autoimmune diseases. Pulmonary fibrosis is common throughout all the autoimmune diseases, but not all of them are progressive. But in some patients, it's really important that we really find the early evidence of these diseases so they can be appropriately managed. It can be a deadly disease, and some of our patients, particularly with scleroderma, die within the first 5 years of their disease. Early identification is really important, and we hope this program will help you understand the CT program diagnosis. So ILD is very common among all the autoimmune diseases, but it has quite a bit different variations. The most common is in systemic sclerosis and in antisynthetase syndrome, where as many as 70 or 80% of the patients will have significant interstitial lung disease. However, they're not the most common autoimmune diseases. Certainly, Sjogren's and rheumatoid arthritis are much more common, and so even though the significant ILD is much less frequent in those diseases, because the disease is so common, you're more likely to see significant disease. So we're going to talk today about particularly rheumatoid arthritis and systemic sclerosis. And the rheumatoid arthritis, we're just still trying to better understand the risk factors. Generally, even though more females get rheumatoid arthritis, males are at greater risk for getting ILD. It's a middle-aged type of onset. There is more smoking in the male rheumatoid arthritis patient that gets ILD, and they are generally patients that have significant rheumatoid factor positive serologies, and so they really are full-blown rheumatoid arthritis. In systemic sclerosis, it's often a very early manifestation, so usually within the first 5 years of diagnosis. It's, again, more common in males, even though it's, the disease is certainly more common in women. And it's also more common in diffuse cutaneous scleroderma, but that's not all of them. As many as 40% of our patients with ILD will have limited cutaneous. The autoantibody is very helpful. Anti-SCL70 or topoisomerase is the antibody that's associated with the highest risk for getting severe interstitial lung disease. So the pathogenesis of fibrosis in ILD is a very complicated process. There's something going on in the vasculature, and it's particularly in scleroderma, but then there's recruitment of various different cells, the cytokines and the growth factors, and they all affect the fibroblasts, and then they turn into myofibroblasts, and then they lay down the collagen, and you get fibrosis, and it's a really circular process that we really need to find ways to break that whole cycle. So some of the patients, as we talked about, have progressive disease, and as many as 30% of scleroderma patients may have progressive disease, whereas at least maybe 70 or 80 have some ILD. So it's really important that we really work hard to identify which patients have progressive. RA, it's not quite so clear how many are progressive, but again, it's a smaller number. And then all the other autoimmune diseases, it's quite variable. So the important thing is that we really look hard for these diseases. And whether you're a pulmonologist who's seen someone that has dyspnea and you hear some rales and you think maybe that they have interstitial lung disease, or you're a rheumatologist dealing with autoimmune diseases, and now you have to really search for evidence of interstitial lung disease. Do you take a good history of whether they have exertional dyspnea, whether they have a cough? Family history of ILD tends to be more important in idiopathic pulmonary fibrosis, but occasionally it may happen with autoimmune diseases. And then again, your physical exam with crackles, that's very important to listen hard. Sometimes we do exertional desaturation, but mostly we do pulmonary function tests. And then we look at the chest imaging. So there are lots of ways to identify whether there's progression. It can be with symptoms. It can be with decrease in exercise tolerance. The physician may say that they're not doing well, or they may have declines in their forced vital capacity or their DLCO, or they may have progression of fibrosis on their HRCT. So the laboratory workup is also, as we mentioned, particularly in scleroderma, we've talked about the SCL70 that's very important, but doing an anti-nuclear antibody using an immunofluorescent pattern is the assay is really important. Some of our direct assays don't give you the pattern, don't give you any other information other than it's positive or negative. So you need to do the immunofluorescent ANA, which is the gold standard, and all these other antibodies, particularly the SCL70 that I talked about, but also rheumatoid factor, CCP, the Sjogren's, the Rho and La, SS52 and 60, anti-synthetase antibodies, U1-RNP, often seen in mixed connective tissue disease. These are all important autoantibodies that can help figure out which kind of autoimmune disease the patient has. So these are the pulmonary function tests, and I'm not a pulmonologist and I'm not going to go into all the details of it, but for our patients that have interstitial lung disease, the most common defect is a restrictive defect, and so that's in the middle panel there, and patients will have a decrease in their forced vital capacity, they'll have a decrease in their FEV1, but their ratio is normal. And then they will have a decrease in their total lung capacity as well as their DLCO. Obstructive disease is not something we usually see, but if you happen to have a mixed pattern where you have someone that has some obstructive disease and restrictive disease, it can be sometimes very challenging to interpret those pulmonary function tests. So here's a patient that's a 43-year-old that has some sinus congestion and clear sputum, and she had an x-ray that showed minimal amount of lower fibrosis changes, scarring, and she had an HRCT. Could you share with us how this looks, Dr. Su?
Thank you, Virginia. This is not an unusual situation where the chest radiograph is relatively unremarkable, or in this case shows a little reticulation down at the extreme lung bases. But what should be surprising, or not surprising I should say, is that this chest CT, how sensitive it is, and you can see ground glass attenuation, reticulation, and even honeycombing.
So in scleroderma, a lot of times we don't even want to get a chest x-ray because we think that it may be normal, and so we go ahead and get an HRCT. Do you think that's okay, not to even bother with the chest x-ray?
I think because the goal is to recognize early or subtle disease at the very inception, I think screening CT is a very appropriate modality. Okay, so HRCT, or high-resolution chest CT, allows us to detect pulmonary fibrosis and allows us to differentiate the radiographic features to help us distinguish between the various interstitial lung diseases. But for HRCT to be effective, there should be an accepted standard protocol that's practiced throughout the country. And here we have an example of such, or parameters, that appeared in the most recent ATS consensus statement regarding the diagnosis and management of idiopathic pulmonary fibrosis. And here they are. So first of all, it should be non-contrast within section imaging. Second, it should be a volumetric acquisition with sub-millimetric collimation. And third, this data set should be reprocessed or reconstructed with contiguous overlapping sections, so there are no skip areas, and also a high spatial frequency algorithm, or this is a fancy term for just an edge enhancement algorithm, and because we are concerned about patterns in suspected interstitial lung disease. It's important to recognize that the radiographic pattern of UIP coupled with a clinical workup that does not disclose any cause for interstitial lung disease is sufficient to diagnose idiopathic pulmonary fibrosis. So when evaluating an HRCT, it's important to first look for imaging clues. For example, a dilated esophagus may point to systemic sclerosis. Likewise, soft tissue calcifications, polymyositis or dermatomyositis, and pleural calcifications regarding asbestosis. In addition to the imaging clues, we want to look at the radiographic features that are indicative for fibrosis, specifically honeycombing, traction bronchiectasis and bronchiolectasis, and reticulation, as well as those findings that accompany interstitial lung diseases, specifically ground glass opacity, airspace consolidation, air trapping, and nodules. With regards to each of these radiographic features, we want to note what their distribution is within the lung. So is it upper versus lower, or is it central / peribronchovascular, and we'll use those terms interchangeably, versus peripheral / subpleural. So let's look at some of these HR features of interstitial lung disease on HRCT a little bit more closely. So first of all, we have reticulation, and reticulation is the result of abnormal thickening of both the intra and intralobular septa, and collectively these linear opacities appear or resemble a mesh or net-like pattern on CT. Here we have various areas within the lung. You can see on image A that if you look closely, there's a lot of these lines that seem to cross over one another and give us a hash mark or hashtag pattern, I guess, in this era of social media. We also see in this magnified image, again, a little closer view of this reticulation that resembles a net or a mesh. And this is, again, indicative of pulmonary fibrosis. Now, to understand the radiographic features that we see on HRCT, it's important to appreciate how they're related to the secondary pulmonary lobule, which is the smallest unit of lung bounded by connective tissue. And on the diagram in B, we see two secondary pulmonary lobules. They consist of acini, and they range in size between 1.5 to 2.5 centimeters. Each of the lobules are bounded by interlobular septa, which contain a lobular vein, and each one of these secondary pulmonary lobules is subtended by a lobular bronchiole or arteriole. So in this case, when we see reticulation, it's a thickening of the interlobular septa as well as some of the connective tissue elements within the secondary pulmonary lobule, which are the intralobular septa. So other features that are indicative of pulmonary fibrosis other than reticulation include traction bronchiectasis and honeycombing. So as you all know, bronchiectasis is an irreversible dilation of the airways caused by a number of causes, whether it's obstruction, infection, or even cases of pulmonary fibrosis. So by definition, traction bronchiectasis results from fibrosis immediately outside of the airway, pulling apart that airway and causing it to dilate. It's easiest to see in the lower lobes and can be consistent with idiopathic pulmonary fibrosis. And here in the middle image, we have a very nice example. And so you can see a very corrugated and dilated airway with varicoid features. But notice how irregular and abnormal that airway looks. But if you look immediately outside, you can see that lung is completely abnormal. And putting two and two together, you should think that the reason why this airway is dilated is because of the abnormal lung, i.e. pulmonary fibrosis. Honeycombing is the most important lesson for the radiographic features here. And honeycombing results from abnormal deposition of collagenous matrix that destroys the characteristic alveolar architecture. So this is the best indicator of end-stage lung, but unfortunately we don't see it in everybody. Honeycomb cysts on HRCT, as you can see, look as abnormal or enlarged air spaces that are irregular in size, bounded or share irregular thickened walls, and can be stacked or layered. They generally range in size between 3 and 10 millimeters, but can be as large as 2.5 centimeters. Other findings that we see on HRCT related to interstitial lung disease can include ground glass opacity. And ground glass opacity is a radiographic term that describes a gray density that we see in the lung. And this veil-like density, although we see it in the lung, it's not dense enough to obscure the bronchovascular markings or structures as well as the airway walls. And this is in contradistinction to consolidation, which are exudates that collect in the lung and obscure the bronchovascular markings and airway walls, as we see a nice example here in the middle image. And finally, we can sometimes see nodules, and these can be multiple or numerous and can be of different densities. So they can be ground glass or solid, as we see in this case here. And in some cases where the pattern is perilymphatic, we may think of diagnoses such as sarcoidosis.
Thank you so much, Rob. Rob has given you a great toolkit for attacking the chest CT, understanding how the lung is becoming abnormal, and how to assign that abnormality to a particular disease state. So I'll show you some of the diseases and how they match up. The first one we're going to talk about is UIP pneumonia. So UIP is kind of an end-stage pathway of the lung. When the lung becomes injured over time and recruits fibrosis and scarring into its connective spaces, it ends up in this end state. And that can start with a variety of different things. It can start with an infection, it can start idiopathically as with IPF, or it can start with an autoimmune condition, and it can progress. And so what we see here are all of the features that Rob has been discussing. You see with the red arrowheads, reticulation and thickening of the septa. You see that at the periphery of the lung, which should be nice and black, you think about all of the structures in your body starting at the center of your chest. Your heart, your aorta, your pulmonary artery, your trachea, the bronchi, all of those are kind of meaty structures. And as they taper, as they go to the periphery of the lung, they should become almost invisible. But in UIP pattern fibrosis, you start to get those structures become prominent and visible. You see thickening of the septae. You start to see airways that you typically shouldn't see. That's the bronchiectasis that Rob mentioned. And so we see that in this diagram. And at the very back of the lung, the bottom of the chest, the green arrows show that honeycombing, that end-stage lung, where those alveolar spaces have collapsed forever and created these stacked air cells that don't exchange oxygen to help the patient and that are irreversibly damaged. So we're trying to avoid that end state of honeycomb cystic change. So we see all three things in this pattern. What we don't see is also important. So Rob mentioned that there are other features of other lung diseases that aren't fibrotic, ground glass, consolidation, nodules. Those are things we see in interstitial lung disease, but not as commonly in UIP and pulmonary fibrosis. So when we don't see those, that's another positive sign that this might be a UIP case as opposed to something different. We see all three things in this particular patient, so we can confidently say by ATS criteria, this is a UIP pulmonary fibrosis case. We'll move to a second case here where we see nonspecific interstitial pneumonia. So this is a non-UIP interstitial lung disease. And so now we're looking for those other features of interstitial lung disease that aren't along the typical fibrosis pathway of reticulation, bronchiectasis, honeycombing. What we do see here is quite a lot of ground glass change. So the red arrowheads in the left lower lobe are pointing to an area that almost looks like a gray paintbrush has painted the lung from one side to the other. The line on the right side, right lung, left side of your image, is showing an area that is relatively spared. That part up against the pleural surface at the very periphery of the lung is relatively black. And as I mentioned on the previous slide for UIP, UIP tends to affect the periphery, tends to create a lot of busyness in an area that is typically very dark. By contrast, NSIP doesn't do that as frequently. It can spare the periphery in so-called subpleural sparing, and it is a much more uniform, homogeneous gray painted onto the lung appearance. You can see some enlargement of airways, but typically you do not see honeycomb cystic change and you do not see a lot of subpleural reticulation. It's important to point out here that a lot of patients can have a little bit of a mixed pattern. You might see a UIP type case where you're confident you see reticulation and bronchiectasis and honeycombing, and you say, well, maybe there's a little ground glass here. Or vice versa, you see an NSIP type case that you think is NSIP, but then you say, maybe this is a honeycomb, maybe this is some reticulation. What we're looking for is the predominant pattern. This patient's lung is diffusely affected with a diffuse lung disease. What is the predominant pattern? And we're not going to be swayed by a little bit of ground glass in a UIP case or a little bit of reticulation in an NSIP case. Moving on to a different disease state, hypersensitivity pneumonitis. So this is a condition that is an allergic response of the lung, and it can go through various stages. The earliest stages, acute and subacute, are the so-called non-fibrotic hypersensitivity pneumonitis. So previously we divided HP into acute, subacute, and fibrotic or chronic. Now we are trying to divide them into non-fibrotic and fibrotic. In both states, we see a very key finding, which is air trapping. Air trapping is one of the reasons that we alter our HRCT protocols. So instead of just doing an inspiratory chest CT, which is your typical routine chest CT, hold your breath, you take your scan, and then you're done, we actually do the scan twice. We'll do once at inspiration, hold your breath, take your image, and then push your breath out, take another image. And then we get another image at expiration, and we're able to compare the two. And when we compare the two, as you can see on these images, you see in the red arrowheads, there are areas of kind of geometric, almost like big, large pavers or flagstones that are different in color from the adjacent parts of lung. It's almost like a patchwork or mosaic of gray and black or gray and darker gray. And that pattern is called a mosaic attenuation pattern and has been seen with air trapping. What that means is that the areas of lung that are overly black are not expelling air as they should. And that is seen in several different conditions. It's seen in asthma, in small airways disease, it's seen in bronchiolitis obliterans, and in the interstitial lung disease world, it's very commonly seen in hypersensitivity pneumonitis. So that's one of the key reasons that we do an expiratory phase on HRCT for ILD patients, because you may be fooled by an inspiratory scan. You may not see the air trapping at all. So quite important to get that. And when you see it, you're going down the pathway of either non-fibrotic or fibrotic HP. And we've already covered the parts that would lead you to know whether or not something's fibrotic. It's the same things. You see a reticulation pattern, you see bronchiectasis, and you see honeycombing. And in fibrotic HP, in contrast to a UIP, IPF, or autoimmune UIP phenomenon, hypersensitivity fibrosis tends to have an upper lobe predominance. So it's a little unique there. So if you see upper lobe predominant chronic fibrosis, you see air trapping, you're going to think fibrotic HP. And the last ILD entity that we'll talk about today is organizing pneumonia. We've heard a lot about organizing pneumonia in the literature because coronavirus and COVID disease causes an organizing pneumonia pattern on chest CT. And so what we see here are some small, rounded, patchy ground glass areas of the lung on both sides. You can see frank consolidation, as Rob mentioned. You can see actual white, rounded, sublobar areas of lung. And you may see a typical sign called the atoll sign, which we see here in the left lower lobe, where there's a rim of ground glass surrounding a central area of black. Typically, we see tumors, pneumonia, it's the worst in the center. So when we see something that looks a little bit more normal in the center, surrounded by ground glass, it's a little striking to us. And that's been characteristic of OP, although it can be seen in other conditions. So we've seen three other ways the lung can become abnormal in interstitial lung disease that's not typical for fibrosis. We've seen ground glass change, we've seen air trapping, and we've seen sublobar consolidation and the atoll sign. Those are things that would move you away from the UIP diagnosis. And now I'll turn it back over to Virginia to recap autoimmune ILD.
So it's really important that all of us think a lot about the autoimmune ILD because these are ones that need to be diagnosed very early. And certainly on clinical evaluation, you hear crackles, may have positive serologies. They certainly have diffuse lung involvement. It can be either NSIP or UIP, or it can be other forms of features as well. And they often will have extra pulmonary manifestation related to their autoimmune disease. So if you feel like you have autoimmune disease, you get your pulmonary function test and you do your HRCT. So I think we're going to do some cases here.
Thank you, Virginia. I'm going to take you through an HRCT example of systemic sclerosis. And just to orient the audience, so we have images A through F, and A is just above the aortic arch, and F is down by the lower lung, just below the dome of the diaphragm. And so we're going to first of all look at to see if there are any abnormalities, and we want to look for those radiographic features that are indicative of pulmonary fibrosis. And so again, these are things like honeycombing, traction bronchiectasis, and reticulation. So here, what we see is predominantly ground glass attenuation admixed with reticulation. We don't really see too much traction bronchiectasis and bronchiectasis, nor do we see any honeycombing. And the radiographic features with regards to the lobe are more dominant in the subpleural periphery and also down in the lower lung. And what's interesting is that if you look very closely at especially images C and D and E, is that if you look at the very outer edges, you see what Juan described as subpleural sparing. When you see this, the combination of findings, you're thinking nonspecific interstitial pneumonia. And one last thing, there's something here that's very important to the audience that's an ancillary finding. And so does everybody or anybody see a dilated esophagus? And so here on many of the images, we see a dilated esophagus, and again, putting the clinical picture together, if it's appropriate, here with this pattern of radiographic fibrosis, we're really thinking about systemic sclerosis with an NSP pattern of fibrosis. So here we have the coronal images, and coronal images can certainly be very helpful when you have diffuse abnormality in terms of helping us find where the predominance of those radiographic abnormalities are. And if I can bring your attention to image C, we can see that most of the abnormality is down at the lower lung in the periphery, and again we see ground glass with reticulation, not too much traction bronchiectasis, and we certainly don't see any honeycombing.
Rob, is this kind of coronal imaging helpful for looking at the extent of involvement? So many of our scleroderma patients just have the very minimal amount, and I think the coronal images at least help me look at it.
Yeah, I think you bring a very good point up, and I think the coronal images are almost indispensable because it really gives you a good appreciation of the extent of involvement in sort of a very small series of images, as well as the location of the abnormalities.
Good. So
with that, I'm going to hand this over to Juan to take us through the next case.
Thanks so much, Rob. So we'll take a look at a HRCT example of a patient with rheumatoid arthritis who's had effect on the lung. And this is in stark contrast to the previous case. So, again, as Rob said, we're going to have the head up here, and we have the feet down here. And then, as we go through sections from the upper lung here down to the bases where the liver is and the diaphragm. And what we're seeing is a lot of those typical findings of UIP that we've already discussed. So we see a lot of reticulation, a lot of busyness at the periphery of the lung, abutting the pleural surface. We see exuberant honeycombing. So the lung bases are almost entirely occupied by these large, stacked, air-filled spaces. This is irreversibly damaged lung that's not going to contribute to oxygenation for the patient. We have enlarged airways. So typically you don't want that airway to be larger than the accompanying pulmonary artery. So as Rob showed you, the secondary pulmonary lobule, the pulmonary artery and the bronchiole travel in the same space in the center of that lobule. And typically they're the same size, or the pulmonary artery is actually a little bit smaller. And here in this case, you can see the enlargement of that airway compared to the accompanying pulmonary artery. That's a sign of bronchiectasis. So we see dramatic change in the lung parenchyma, and we see some signs that can tip you off that this might be an autoimmune patient. So this is a UIP pattern. We see the signs of fibrosis. We see reticulation, bronchiectasis, fibrosis. We don't see a lot of ground glass. We don't see the other signs that can be seen in other ILDs. But we do see some things that might tip a viewer off that maybe this is an autoimmune process, a rheumatological or connective tissue disease process. One that has been described in the literature, exuberance of the honeycombing, large and extensive. Two, anterior upper lobe. So we see that the upper lobe is affected, but it's anterior. That's more typical for autoimmune than in, say, IPF. And then the third thing is a straight line or straight edge sign, which we'll see on the coronals here, which is a relatively straight edge to the fibrosis on a coronal image, again, showing how vital those coronal images are. And if we contrast this case, to keep this in your mind, the size from here to here, and then let's go back to Rob's case. Look how large this hemithorax is. This patient doesn't have a lot of fibrosis yet, doesn't have restriction or not nearly as much as this patient. This patient, you can see the lungs are physically getting smaller. That diaphragm is getting pulled up. Those airways are getting pulled open. This is a fibrotic patient whose so much lung is being taken up that they cannot expand their chest to pull in air and oxygenate. So you can see the restrictive process by watching the diaphragms, and you can not only compare two different patients, you can compare the same patient and watch these diaphragms creep up over time on the coronal or sagittal images. So now I'll turn it over to Virginia for an overview of patients with interstitial pneumonia, but with autoimmune features and not a specific diagnosis like we've just discussed.
So this is a sort of new entity. For years, we've had patients that have interstitial lung disease that have what I call some sort of autoimmune disease, and we've really not been able to characterize them. They were lung predominant or autoimmune lung disease. And so a few years back, the ERS and the ATS came up with these guidelines so that we could classify patients into this category. And in order to be classified as IPAF, as we call it, there are 3 different domains, and you have to have 2 of them. So there's a clinical domain with a bunch of rheumatological, Raynaud's skin, arthritis types of features. And then there's the serologic evidence, a lot of things that I brought up earlier. And then there's the morphologic domain, in which either it's an HRCT, or if you happen to have a biopsy, or if you have multi-compartmental, both the pleura as well as the lung involved. And so if you have 2 of those 3 categories, you can be classified as IPAF. And so at least we are beginning to better understand this patient population. The presence of having these features leads to the diagnosis. And the question is, what do we do about these? And that's what we're just learning about this patient population.
All right, so let me take you through this first example of an IPAF case. And again, just to orient you, we have image A through F. A is about the level of the aortic arch, and F is down, way down by the costophrenic sulcus. And see, clearly you can see the diaphragm here. Again, first of all, when you're looking at this, you want to look for those radiographic features of fibrosis. So you want to look for reticulation, traction bronchiectasis, and bronchiolectasis, and most important, honeycombing. And so what's pretty clear is that as you start looking at these images, you can see very nicely reticulation and not too much traction bronchiectasis and bronchiolectasis per se, maybe a little bit down at the extreme bases. And again, you should start thinking that this may be a fibrotic lung process, although less involved than some of the other cases we've showed you, especially Juan's cases. And we also see that there is really no honeycombing. So we also notice the distribution. It's down in the lower lung and out in the periphery. So when somebody looks at this, depending on their confidence level, and again, this is not 100%, and everybody interprets this with a little degree of confidence. When you look at this, those who are really confident might put this as a probable UIP pattern radiographically, and others, and probably more so, would put this as indeterminate for UIP pattern. And depending on what the remainder of the clinical workup, this will tell you what the diagnosis may be. Again, we can look at the coronals, and very nicely you can see that most of the reticulation is down in the periphery and favors the lower lung, although we do see some in the upper lung as well. And again, the coronal images are a very nice way to not only look at the degree of involvement, but also the distribution. So I'm going to hand it over to Juan to go through our next case.
Thank you, Rob. So let's go to another case where we have many of the features that we're seeing, but a little bit more striking. So this is a second patient with interstitial pneumonia, autoimmune features, and we see a much more striking abnormality throughout the lung. So we know that UIP is a basilar predominant, peripheral predominant pattern, and that's what we see here. So we see at the lung bases, we see stacked cystic air cells that are stacked on top of each other. And I usually use the word stacked because paraseptal emphysema, which is often seen, tends to be one row. It tends not to be stacked on itself. So that can be one way in smokers that you can try to differentiate between, hey, is this honeycombing or is this just paraseptal emphysema in a smoker? We also see that enlargement of the airways. We see the reticulation. And we see that it is affecting the upper lobes as well. We do think of UIP as a basilar predominant process, but that doesn't mean it spares all the rest of the lung. We do see it in the upper lobes, just not as severe as we find it at the costophrenic angles, as we see here. We see the same images on coronal. Again, the value of these coronal images showing the distribution, basilar, peripheral, honeycombing, bronchiectasis, reticulation. We don't see a predominance of other findings like ground glass and consolidation. That lets us confidently diagnose something like UIP and then combine it with the clinical picture, the autoimmune features, to place the patient in the IPAF designation. So now I'll turn it over to Virginia for a summary of IPAF.
So patients with ILD and features of autoimmune disease that do not meet criteria for a connective tissue disease are the ones that are given the IPAF diagnosis. Raynaud's is the most common clinical feature, and ANA positivity with that immunofluorescent ANA is the most common serologic. The difficulties lie when there's variability in the predominant pattern of the ILD on HRCT, whether it's UIP or the NSIP. These are all just very challenging patients. There are independent predictors of mortality, particularly the UIP pattern, even in IPAF, and as well as cigarette smoking. But at this point, there's really no defined treatment strategy, and we're really trying to figure out how to sort these patients out. So, in summary, we've talked about the importance of making early diagnosis of ILD in autoimmune disease patients, but it's also extremely important that we follow these patients very closely. We follow their symptoms, we follow their ability to exercise. This is where we do 6-minute walks and use forehead probes so we don't get Raynaud's problems with the fingers. Then we do pulmonary function tests, and we follow pulmonary function tests, the FVC and the DLCO. And then we follow the progression of fibrosis on the HRCT.
And remember the key HRCT features associated with fibrosis: reticulation, traction bronchiectasis and bronchiectasis, and mostly important, honeycombing.
Now, we've covered a lot of radiology, a lot of different images. If you feel like you need to remember one versus the other and you don't remember what we said, don't worry. There's a great resource online at Radiology Rounds, ipfradiologyrounds.com, and that can also be downloaded as an app. So if you want to review any of these features, both the imaging findings of fibrotic ILD and non-fibrotic ILD, that resource is there for you. Thank you for attending the program. We'll now have a Q&A session where you'll be able to submit questions and we'll answer them, whatever you'd like.
Well, while we're waiting for questions, I'll have one to ask you.
Sure.
Both. I struggle with trying to figure out how to determine how much progression on the HRCT. I mean, we see changes in their pulmonary function test, and then we ask our radiologists, is there progression? And I don't get great answers from my radiologist.
Yeah, I sympathize. You know, when you have a pulmonary nodule, there are a lot of tools to kind of quickly measure the pulmonary nodule and say it was 10 by 10 millimeters last year and it's 12 by 12 millimeters this year. With fibrosis, where you're trying to decide, is this area reticulation or not? Is this area true honeycombing? Is this airway affected? It can be hard to figure out where your boundaries are and what you're going to count as abnormal. As you know, many of these patients end up with acute exacerbations, so how much of that is playing into the changes in what we see on the CT? So I think you just need aspiration. These patients often suffer from reflux. So we just need to kind of have somebody with good eyes take a look at that scan, make a good faith effort to look at every scan available, and try to come up with a decision of, can I honestly say this has progressed? And I know that there are quantitative ways to approach lung disease. What do you think, Rob?
Well, outside of quantitative techniques, I think one very useful mechanism, or what I like to do, is take the old CT and compare it to the new one, but look particularly where there was not fibrosis before. So look, if it's a lower lung, mid-lung predominance, start looking at the edges of the upper lung beyond where the fibrosis had been. That could, again, as the disease gets worse, it certainly would progress. The other really helpful tool is to look at the areas that were spared previously. So if there are lobules or collections of lobules that were less affected, you'll be surprised that when you come back with disease progression, those areas may be completely contracted or changed into honeycombs.
Okay. We have a question here. When I see ground glass on the scan, how concerned should I be to look out for potential lung damage or fibrosis? Is it a precursor of fibrosis?
That's a great question. So
lots of ground glass.
I think that there's some controversy there. There are some folks who believe that NSIP, for example, is kind of your gateway to progressing to UIP pattern, and some people who don't, who feel like NSIP is its own entity. I think ground glass, particularly in cases of, for example, a drug phenomenon, hypersensitivity pneumonitis, and as we've seen with COVID pneumonia, organizing pneumonia from COVID, we do see those areas of ground glass progress to frank fibrosis. So those are the entities where I would be concerned about something like that. So it's something that's always on our mind. When we see fibrosis and UIP pattern, what did it look like 2 years ago?
Right, and I think the other thing is that as good as our techniques are, ground glass can just represent simple alveolitis in the case of interstitial lung disease, or it may be representative of a very early fibrosis, or what we call sub-resolution fibrosis. And again, so we're not only looking for the density of ground glass, but what is that distribution? And was it there before? And if it's changing? Because if you see ground glass nodules and they're clustered, you're thinking more infection or aspiration than interstitial lung disease.
That's a great point, Rob. We have another question that I think Virginia can take. For patients with IPAF, do they later receive a more specific diagnosis?
So some of them do. Some of them we see just because they're very early in their disease, but many of them really never fulfill the criteria. So like in scleroderma, we have patients with Raynaud's who never developed skin involvement. If they have a nucleolar pattern ANA, which has a high amount of lung disease, they may never get to reach the criteria. We did a recent study, and of our 75 IPAF patients, 50% of them, we couldn't even figure out which of the, what I called silos of the different diseases. I was hopeful that it was going to be scleroderma, RA, et cetera. But many of them, you can't even get a hint of. So it's a really challenging group of diseases.
So do you treat them as separately like IPAF, or do you treat them as like a scleroderma-leaning IPAF?
That's what I was trying to sort out with my group of patients, because that's what because certainly dermatomyositis and lupus have much different treatments than scleroderma and RA as far as baseline autoimmune treatment of it, but we couldn't do that and 50% we couldn't do that.
Got it.
I have one question for Juan. I know you spoke on fibrosing and non-fibrosing hypersensitive pneumonitis, and certainly that can be on people's differential diagnoses, not only as a radiologist, but as the clinician. So how often should you be getting expiratory imaging in your HRCT protocol?
That's a great question, and I think many of these patients, we will also sometimes do prone imaging for these patients, as you know, in order to look at the back part of their lung when it's up against the sky, as opposed to being dependent and suffering from atelectasis potentially. And a lot of these patients don't like to handle that. So we always do it for the first scan. And then the subsequent scans will depend on what that initial diagnosis was. And if we are confident that, hey, this first CT scan didn't show anything at the back of the lungs that we're worried about, didn't show any signs of air trapping, then we'd be confident following that patient with, say, UIP or an SIP with just an inspiratory HRCT, particularly if the patient can't tolerate it.
Right, and I think for the audience, it's really important that your first HRCT on these patients that have shortness of breath or chronic cough do include expiratory imaging in that protocol to make sure that you don't miss hypersensitivity pneumonitis.
So we do have a question about the role of fibrosis in mediating and influencing inflammation. I am not a basic scientist, but I know these are very complicated pathways, and particularly in the autoimmune diseases, there's such an interplay of the inflammatory with the fibrotic pathways. There's something driving the fibrosis. Is it inflammation? I don't know which it is, but there's all kinds of interplay of activity. So there's a role, but we're not quite smart enough, or at least I'm not quite smart enough. Okay. Okay. All right. Well, thank you very much for these thought-provoking questions. Have a great rest of your day. Thank you very much.
Bye, everyone.
Thanks, Lowell.